and how the dose of statins are different. How do we use the different various statins to better effect? So, and what are the new lipid guidelines which have come out in 2018? What are the various goals and strategies to improve outcomes? So, talking about metabolic syndrome, as we know the clinical diagnosis of metabolic syndrome, few things, features that we see is an elevated waist circumference. It's very simple. Males more than 40 inches, females more than 34 inches. We have elevated triglycerides. We have reduced HDL. We have presence of hypertension, and of course, elevated fasting glucose. Patient may not be a diabetic, but even elevated fasting glucose. These are all the various features of the metabolic syndrome. And if you find features of this, the clinical diagnosis of metabolic syndrome is made. And why is it important? Because metabolic syndrome is associated with an increased risk of atherosclerotic cardiovascular disease, future diabetes, and of course, important cause of all-cause death. And as we know, as the activity levels are going down, we have seen a sharp increase amongst the children and then finally adults. Most of the outdoor games are now not so popular. Most of the children are into video games and on their telephones, which has led to a lot of childhood obesity. Hence, lifestyle therapies are very important in all these age groups, and metabolic syndrome is a risk-enhancing factor, needs statin consideration in adults to reduce the atherosclerotic cardiovascular risk. Who should be on statin therapy? Of course, we have to always emphasize the healthy lifestyle, that is diet and exercise. Now, depending on the age, whether the age is between 0 to 19, of course, with familial hypercholesteremia, where we know the total cholesterol is more than 350, LDL might be more than 200, whatever age, we have to start with statin. Age 20 to 39, we have to estimate the lifetime risk, and we should consider statin if family history of premature atherosclerotic disease and LDL is more than 160. So remember, even if the patient is asymptomatic, should do the lipid profile, and if he has a father who had an MI at 40, 45, we should consider statin therapy in these patients. Age 40 to 75, LDL should be below 190. We should get it below 100 in fact, and we should consider statin based on 10-year risk and presence of risk enhancing factors which we have just discussed. And if the age is more than 75, we have to consider statin based on clinical assessment and the risk discussion. So these are where we can consider the possibility of statin. But patients who must be on statin, and we must counsel them and necessarily put them on statin, is age 40 to 75 and LDL is more than 190. We need not assess the risk also, and straight away we should initiate high intensity statin. Again, by high intensity, we mean 40 to 80 milligrams of atorvastatin and 20 to 40 milligrams of rosuvastatin. Age 40 to 75 with diabetes and an LDL between 70 to 190, we have to initiate moderate intensity statin therapy, that is 10 milligrams of rosuva or 20 milligrams of atorvastatin, regardless of the CVD risk. And we should consider high intensity statin if we find that the risk is higher. Age 20 to 39 with long-standing diabetes, that is diabetes more than 10 years and more than 20 years for type 1 diabetes, it is always reasonable to initiate statin therapy. Age 75 with diabetes, reasonable to initiate based on the risk discussion. What are the predisposing factors when we put the patient on statins for new onset diabetes mellitus? A moderate increased risk of new onset diabetes mellitus, it has been seen. If these are the predisposing factors, we have a BMI of more than 30, a fasting plasma glucose more than 100, patient has metabolic syndrome, has an A1C of more than 6, and we are using high intensity, definitely this patient can develop new onset diabetes mellitus. But what do the guidelines say? Guidelines say that we have to see the risk benefit ratio, and if we feel that giving this statin is going to be more beneficial for the patient, we should definitely give as compared to the increase in blood sugars, which can be easily managed with OHAs. So, but it is our duty to inform the patient that he might develop over diabetes. But if we explain to them the benefit that he is going to achieve with high dose statin, I think it will be a reasonable reason to give high dose statins. We have to understand the risk benefit ratio. Risk is based on the intensity and the amount of statin that we are used. The FDA applies this as a class warning. The risk is small, and the benefit is greater. Moderate potency statins should be used, but will not achieve as high as an LDL reduction. This is about a primary prevention case where we have a 50-year-old man with a history of hypertension and hyperlipidemia. Blood pressure is high, total cholesterol is 246, LDL is 1, triglycerides are 150, fasting glucose 110, and his 10-year calculated risk is 8.7%. Now, this patient is reluctant to start statin therapy due to fear of diabetes. I think if we tell him that, listen, the risk of diabetes is not so much as you will benefit with statin therapy, it will be a great help in reducing his future risk for coronary artery disease. So remember, and reduction in the future events of myocardial infarction or unstable angina, which can result in an acute coronary syndrome. To conclude, the development of new onset diabetes mellitus definitely depends on the statin and the dose of statin that is being used. The 2018 cholesterol guidelines provide strategies on how to minimize this risk. We have to do repeated risk assessments. We can do the cardiovascular disease score. We will do the calcium score. Lifestyle modification can significantly reduce the risk. And for a patient at risk of developing diabetes mellitus, we should choose a statin that has neutral effect on glucose. As I told you, that is pitavastatin. And of course, it's the team management with education, adherence, and identify medicines that can contribute to glucose changes. Thank you.